Thank you, Shed. I shall be talking about cataract surgery in eyes with Fuchs dystrophy, decision-making, no financial disclosures. Fuchs dystrophy is a bilateral corneal dystrophy affecting the endothelium, has an autosomal dominant inheritance with a female preponderance. Clinically, under diffuse illumination, you can often miss this unless you make a slit and look at the decimus membrane for the guttate changes. The guttae are seen better on retroillumination. On specular microscopy, you'll see the dark spots. On anterior segment OCT, you can see a thickening of the decimus membrane, and regional pachymetry will show increased corneal thickness. The guttae lead to loss of endothelial cells with variation in size and shape. You can get posterior stromal folds leading to epithelial edema, and then finally subepithelial fibrosis and superficial vascularization. The symptoms of Fuchs is the corneal dystrophy and the cataract are almost similar, except that the early morning blurring of vision is a symptom which is very specific to having the corneal edema. The clinical decision is whether to do the corneal surgery or do a combine or do the cataract surgery first. In a normal cataract surgery, there is 8 to 10% loss of endothelial cells, depending on the density of the cataract, the axial length, anterior chamber depth, and the pupil dilatation. And a lot of these eyes with compromised endothelium, you tend to use the soft shell technique of a combination of dispersive and cohesive viscoelastic. The study looking at the cataract surgery in Fuchs dystrophy by Sietzman, they found that eyes which had preoperative pachymetry of 640 microns, 22.2% went on to require a keratoplasty, whereas eyes with a preoperative thickness of less than 640, only 2.4% required a subsequent keratoplasty. The advantage of doing a cataract surgery alone is that you can avoid all the complications that are associated with a corneal transplantation, namely endothelial keratoplasty, no need for frequent follow-ups, long-term use of medication. However, the disadvantage is that with passage of time, as the disease progresses, you can have visual deterioration. If you decide to do a cataract surgery, ideally phacoemulsification is preferred, but depending on the density of the cataract and the overall situation, you can choose to do a manual small incision or extracapsular cataract surgery. In eyes which have very shallow anterior chamber, sometimes I prefer to do a limited pars plana vitrectomy, which increases the anterior chamber depth, increasing the working space, thereby reducing the endothelial cell loss. Remember to put in a hydrophobic intraocular lens, as the hydrophilic lenses can develop opacity with the air field with endothelial keratoplasty. Because of to overcome the hyperopic shift, you can aim for -1, -1.5 as the post-op refractive target. Use very sharp knives because when you're making your paracentesis, the decimus membrane, usually the attachment is not very tight. So you can detach the decimals both at the side port of the main incision. Use the soft cell technique, VSS. Avoid intracameral medications because the endothelium is already compromised. You may not want to use medications to either dilate the pupil or stain the capsule, or at the end of the surgery using intracameral antibiotics. I would prefer to secure my wounds rather than try and hydrate them, because while hydration, you can further detach the decimus membrane. And it's always advisable to leave a mid-size air bubble at the end of surgery. So if you do have some partial detachment near your incisions, this air bubble can help reposit the decimus membrane. You can use steroids post-operatively with a greater frequency. Sometimes you need hyperosmotics. Watch out for the intraocular pressure. And if you do develop edema, it may take sometimes 8 to 12 weeks to resolve. So this is how the Fuchs dystrophy progresses. Well, ideally, if your corneal thickness is less than 650 and your cell count is more than 1,000, you can think about doing a cataract surgery alone. If it is more than 650, but the cell counts are still between 800 to 1,000, you can do a cataract surgery, but understanding that there may be a greater risk of post-operative edema. But if the PACI is more than 650 and the cell counts are less than 800, maybe better to perform a combined surgery or do an endothelial keratoplasty first, followed by subsequent cataract surgery. We often use central corneal thickness as an indicator of endothelial function, but there have been some recent papers where on tomography, they have found that looking at the regional pachymetry increase in the central corneal thickness. And if you look at the posterior elevation, you find a focal posterior depression, which can be earlier indicators of the Fuchs dystrophy, and on serial tomography, you can find out if the disease is progressing. Similarly, looking at the corneal thickness, the ratio between central and peripheral cornea can also give you an idea about the disease progression. You have newer anterior segment OCT, which gives you a 3D imaging, whereby you can look at the guttae and maybe quantify them. The decimal stripping only can be performed when you have the changes, the guttae changes are located to the central 4 to 5 millimeter area only. So you just go and do a decimal stripping in the central 4 to 5 millimeter area. It's pretty much like doing a capsulorhexis. Here you are doing a decimetorhexis. And after that, you put your patients on topical steroids and also topical rho kinase inhibitors like ripasudil 0.4%. And they've found that the edema resolves over a 1 to 3 months period, and patients recover good visual acuity, and they may not, the Fuchs dystrophy may not progress in the immediate period. But if you have advanced changes like this may not work because the guttae extend all the way to the periphery. You may need to think about doing endothelial keratoplasty, which is much better than traditional penetrating keratoplasty. You have better refractive outcomes, lower risk of rejection. So here, the basic surgical procedure involves removing the unhealthy decimus membrane, followed by inserting donor lenticule. Like in DSEC, you have the donor lenticule with some amount of stroma, whereas in DMEC, you have just the isolated transfer of the decimus membrane. So once you place inside the eye, the donor disc is, or the donor DM is unfolded, and then you use air or gas for tamponade to hold the donor disc in place, and that basically completes the surgery. Combined surgery with cataract and endothelial keratoplasty, especially DMEC, the cataract surgery has had no adverse impact on the outcome of surgery or the endothelial function. This is a patient who has undergone bilateral, in a sequential manner, a phacoemulsification with endothelial keratoplasty, and at 2 and 3 years, you can see that has good visual acuity, unaided of 6.9, improving to 6.6, and cell counts are also pretty good. There's a patient who has had, with Fuchs dystrophy, who has had a cataract surgery alone and a non-resolving corneal edema. They had a DMEC done and is maintaining good vision at 3 years with good endothelial cell count. These are again some of the other cases where this has been done. This is a young patient. She is 45 years old, and there are no lenticular changes with Fuchs. So we went ahead, just did a DMEC alone, and patient recovered good vision. The advantage of doing DMEC in a phakic eye is that a subsequent cataract surgery, you can plan for the the newer lenses, either the toric lens or you can place your multifocal lens as well. That's the change you see on anterior segment OCT. The refractive shift in DMEC is much less. Initially, immediate post-op, you may see a small hyperopic shift. That's resulting from the faster resolution of the central corneal edema. So that makes the posterior curvature more steep. And when the peripheral corneal edema resolves, this curvature gets back to normal, and that reduces the short-term hyperopic shift that you see. So in this series, where in phakic DMEC, only 4.7% developed cataract, which required surgery, and all eye achieved 20/30 or better, and were within plus or minus 0.5 of the target refraction. And the endothelial cell density did see a decrease of about 20%, but which was not significant. So if you have Fuchs dystrophy, you can do cataract surgery alone. If it fails, you can plan for endothelial keratoplasty. If it is limited to the central area, you can just do a decimal stripping only, followed by a cataract surgery later whenever the cornea decompensates. You can either combine the surgery, or you can go ahead and do the endothelial keratoplasty first, and then do a subsequent cataract surgery at a later date. This is just a flow chart just to show you that if you have patient with Fuchs dystrophy, if you have an asymptomatic patient, you don't do anything. If you have a symptomatic patient with a clear lens, then you can look at the guttae. If they are limited to the central area, you just do a decimal stripping only, which can be successful or unsuccessful. If it is unsuccessful, you can consider DMEC. Or if the guttae extends beyond the 5 millimeter and the anterior chamber depth is sufficient for a safe cataract surgery at a later date, then you can consider DMEC. But if the anterior chamber depth is less than 3 millimeter, then no point doing a DMEC alone, because the subsequent cataract surgery may result in an increase in endothelial cell loss. If there are lenticular changes, you look at the pachymetry and the endothelial cell count, If the pachymetry is less than 650 and good and endothelial cell counts are above 1000, you can still go ahead with the cataract surgery alone. Place a hydrophobic IOL. You can aim for a slight myopia in the target refraction, and then subsequently perform DMEC whenever necessary. Yeah, and if your pachymetry is more than 650, then you choose the other options. That's in conclusion. I think that's what I have covered. Thank you. Thank you for a patient hearing.